So we're excited to have a guest with us today. Dr. Leanne Lynham is joining us from Children's Healthcare of Atlanta. So she'll be discussing challenges of ovarian torsion, and then afterwards we'll have some additional case review and discussion as well. So with that, I will go ahead and turn it over to you, Leanne.
Thanks, Jeffrey. Thanks for having me. I don't have anything to disclose. Ovarian torsion is a favorite topic of mine, starting when I was a fellow a lot of years ago. So I'm excited to talk about this today. So just some basics. Ovarian torsion, the incidence is about 5 per 100,000 females, ages 1 to 20 per year. Of course, it occurs in older females too, but this is the age group we're interested in. And it's the 5th most common gynecologic emergency. The clinical presentation is really nonspecific. Classically, they present with acute onset lower abdominal pain, which is more common on the right, which to make it confusing with appendicitis. And often it is associated with nausea and vomiting, about 75%. And at least half of the affected patients have had a previous episode of similar pain. So we all know that the ovary has several different places it can twist. The fallopian tube can twist. It can twist around the ovarian blood vessels. It can twist along the uterine, the ovarian branches of the uterine artery. So there are just lots of different mechanisms, which also makes it confusing because there's more than one blood supply. So how do we image ovarian torsion? Classically, we use an ultrasound of the pelvis with Doppler as the first line. And this is great because it's widely available, it's inexpensive, there's no radiation, and we can use Doppler to look at blood flow. Limitations in the pediatric population is we use a transabdominal approach, which requires a distended urinary bladder. So that can either take time or require placement of a Foley catheter. And what do we see? We see an asymmetrically enlarged ovary. In about 40%, the adnexal ratio, so comparing the abnormal side to the normal side, is greater than 15. And the volume is usually greater than 20 milliliters. You can see multiple peripheral follicles. So the follicles are shifted to the outside of the ovary. And a lot of times the ovary will not be in its normal location. So here is a case of ovarian torsion, and you can see on the left-hand side of the screen, this ovary is enlarged. The volume is 195 milliliters. Sorry, I had to get my glasses to read those numbers. And then the contralateral ovary is 12 milliliters. And this had a ratio of 15. So this ovary is 15 times the size of this other, of the left ovary. And when we put Doppler on, there is no flow. Here is another torsed ovary, and I'm only showing you the right ovary. Its volume was 86 milliliters, and the contralateral side was 18 milliliters. And you can see that this ovary is displaced. So here's the bladder and the uterus, and this right ovary, instead of being on the right side where we would expect it to be, is displaced posterior to the uterus. So pitfalls for ultrasound for the evaluation of ovarian torsion. The presence of flow is unreliable. If you see absent flow, that's more specific, but the presence of flow really is not. Sometimes it's hard for these girls to get a distended urinary bladder. So that can make seeing the ovaries difficult. In large patients, seeing the ovaries is difficult, and obtaining spectral waveforms can be difficult in large patients. And then in prepubertal ovaries, those can also often be hard to find, and it can be hard to obtain spectral waveforms. So 50% of ovarian torsions are associated with a mass, and this can be just an ovarian cyst, a benign functional cyst. It can be a teratoma. But if there is a mass, if it's greater than 5 centimeters, the risk of torsion is increased. And here's a case. This is a patient who had a hemorrhagic cyst and torsion. And you can see that there is some blood flow, but when they took this patient to the OR, it was a hemorrhagic cyst with a torsion. And here's another case of a hemorrhagic cyst with a torsion. And there is a little bit of blood flow to this peripheral bit of ovarian tissue, but again, this was torsed in the OR. Now, here's a case of a hemorrhagic cyst without torsion. So it looks pretty similar to those other two cases that I showed you. We don't see a lot of blood flow when we put it on, only peripheral blood flow like we saw kind of on the other two cases. So you can see when you've got a hemorrhagic cyst, it can be hard to tell if it's torsed or not. And remember, I said if it gets above 5 centimeters, your risk of torsion increases. And this was 5.3 centimeters. So really hard to tell. So here is a case of a patient who had bilateral ovarian cysts, and you can see the simple cysts bilaterally. The right ovary, they measured the ovaries separately, and it was 3.8 milliliters. And then the cyst was, when you added the ovary volume plus the cyst volume, it was 333. And then on the left, you can see this ovary is a little bit bigger, and the cyst is a little bit smaller, and added together, they were 293 milliliters. The patient went to the OR, and there were, of course, bilateral cysts, but that left ovary was torsed. And here is another case of a large ovarian cyst without torsion. So you can see a little bit of peripheral ovarian tissue, a large cyst, blood flow in that tissue, and this patient did not have a torsion. But again, pretty hard to tell from that other case with that had the torsion. So when you look at the American College of Obstetric and Gynecology recommendations on pediatric torsion, you know, exactly what I talked about earlier. The most common symptom is sudden onset abdominal pain that's intermittent and associated with nausea and vomiting. And they say there are no clinical or imaging criteria sufficient to confirm the preoperative diagnosis of adnexal torsion. And the Doppler flow alone should not guide clinical decision making. And they say, although more than a half of cases of pediatric and adolescent adnexal torsion occur in the setting of an adnexal mass, cancer rarely presents as torsion. So usually if it's torse, it's a benign mass. But really, I mean, this slide is a lot of words and a lot of information, but what I wanted to point out is that according to ACOG, there are no clinical or imaging criteria sufficient to confirm the preoperative diagnosis of adnexal torsion. And I would qualify that saying there's no single one that can be used alone. So if there's no imaging or clinical criteria to confirm the presence of torsion, what do? How do we diagnose it? Well, I mean, we could do CT, but that has the limitations of radiation, and CT really has pretty poor soft tissue resolution. And here's a case of a torsion on CT, and you can see here's the enhancing uterus, and here is the left ovary, actually it's the right ovary, sorry, here's the left ovary over here. The right ovary is displaced, and you can see this nicely, well, not nicely for the patient, but you can nicely see this twist in the tube as it goes to the ovary. So that this was an ovarian torsion. We could do MRI, but MRI is not widely available. and it does have higher cost. I know there are several centers doing a lot of work on MRI of ovarian torsion, and especially I've read a lot of work from, or seen a lot of presentations from Cincinnati, but not everywhere has scanners that they use for emergency patients. We would have a hard time getting a patient in at our institution. But again, the findings are similar. There's an enlarged ovary, peripheral follicles displaced into an abnormal location. And you can see the twist right here and right here. We could do transvaginal ultrasound. This has limitations in that, really we can't use it in prepubertal patients. And a lot of places, you want the patients to be sexually active, or at least tampon users. And we actually did a study that we presented, my friend Judy Squires and I, that we present SPR. We did a survey of, and we found that not everywhere is doing transvaginal ultrasound. 24 versus 15 not doing it as standalone children's hospitals. Children's hospitals that are attached to an adult hospital are probably more likely to do transvaginal ultrasound, but not everywhere is doing transvaginal ultrasound in peds yet. But this is what it looks like on transvaginal ultrasound. So you can see the transducer in the vagina, and we're much closer to the ovaries than we are in transabdominal. And you can see the whirlpool sign that they talk about in adults all the time, which I have found that we very rarely see in transabdominal ultrasound, but makes it easier to see. Sorry. But what we are doing at our institution and other institutions is we're using a composite adnexal torsion prediction score. And this is actually an article from Cincinnati where they developed this score. And they used 3 factors that go into the score. The first one is vomiting. The second one is adnexal volume. And the third one is adnexal ratio. So they looked at their score, and they found that greater than or equal to a score of 4 had greater than 25% rate of torsion. And so they said that this score can triage patients for surgery. We have actually modified the score and looked at it at our institution. Our modifications is we added an intermediate volume, giving a score of 1 for menarchal patients. So you can see that the volumes that we're using are really high. So less than 75 milliliters in menarchal patients gives these patients a score of 0. And then the ratio, we say 21. And then there's a sort of intermediate ratio of 2 to 21. And then the third risk factor is vomiting, and it's just a yes or no. And so we retrospectively applied this score to 10 years of our surgical patients. And so obviously there was a selection bias because 93% of the surgical patients had torsion. But you can see that the composite score had a high odds ratio for ovarian torsion. So right here, compared to the other variables independently. And so that was the retrospective. And we are continuing this prospectively with a couple other institutions. Jeffrey is working with us, and then I believe Salt Lake Children's, because that's where our gynecologist is now. But we're prospectively looking at this, and we found that it is in fact predictive of torsion. And so basically what we found is that that when we look at the score and additional variables, that that the score is predictive. So this was the retrospective, and we found that it is predictive of torsion. And then the prospective, when we look at all patients and the surgery patients, again, it is predictive of torsion. And there were some other variables that we found were predictive, and we're going to look into those more. But what I want to point out, the most important thing is that the negative predictive value of a score less than or equal to 3 was 99%. So I think that this is a great tool to triage patients who needs to get and decide who needs to go to surgery. So just a summary of that. We found that the score does effectively predict torsion, and that the associated factors we're going to look into a little bit more, but there are some associated factors that help you decide if there's torsion, and they were statistically significant independently. And so a CAT score of greater than 3 had a 90% sensitivity, and greater than 4 had a 90% specificity, and a positive predictive value of 56%, and a negative predictive value of 99.2%. So among the premenstrual girls, I've had people say, maybe the next time I publish something on torsion, I can address the premenstrual girls. Our N so far has been too small to draw robust conclusions. We're hoping that the multi-center will bring in more premenstrual girls. It's just that, the numbers of those that come in with pelvic pain and a torsion, unless it's prenatal, are just so small, it's hard to get enough numbers. But the CAT score was trending toward significance. So bottom line is that ovarian torsion is difficult to definitively diagnose. Clinical symptoms and imaging findings can be nonspecific, but when you combine the clinical and imaging findings and use a composite score, that can predict the risk of torsions, or the risk of torsion. But really, in the setting of torsion, teamwork is essential. You've got to communicate with your emergency physicians and surgeons. So that is all I have. So
I think, just to start off, I think staying on the topic of ovarian torsion, I'd really like to just kind of dive into that a little bit more and have some discussion about it. So what I have displayed here is kind of our clinical pathway that we've put together at Children's Colorado, just as far as kind of how we approach these things. So, but before I kind of get into the cases, I kind of wanted to open up a couple of discussion points just to how we kind of optimize our imaging of these patients. So we, like you mentioned, you can do both transabdominal and transvaginal imaging. I'm curious if you guys have specific criteria, Leanne. I know you mentioned a couple as far as either tampon use or history of sexual activity. How do you guys approach that at your institution? Do you guys have specific criteria for kind of who is eligible for getting transvaginal versus transabdominal? How do you guys approach that?
We have, I'm reading your slide. Our decision-making process is pretty similar to yours. It is a shared decision-making between the provider and the patient. But the patient does need to be sexually active, or a tampon user, or have had a speculum exam. We don't do them in patients under 13. So, and we always start with a transabdominal. So, they still, now, if the patient's having a hard time filling their bladder, or it's taking a long time, and the clinician has ordered a transvaginal, we will do a transabdominal with an incompletely full bladder, and then move on to the transvaginal sometimes. We're not going to do a Foley catheter and a transvaginal. But we usually try to start with a transabdominal with a full bladder. And then if that's sufficient, then we don't do the transvaginal. So.
Yeah, and we previously had kind of more strict guidelines, but our GYN team kind of made the point that, you know, some of their patients, you know, particularly those that had mental disabilities and, you know, were not necessarily meeting some of these criteria that we had, they felt that they would clinically still benefit from a transvaginal exam, but, you know, they were being excluded by our prior criteria. So kind of our current state is that basically if the patient or their parent consents to the exam and they, you know, are aware of what we're planning to do, then, and the ordering provider feels that it's clinically necessary, then we allow those to be done. So I know that's, most people I've talked to have a little bit more strict criteria than I feel like we do. And I don't know. I don't know what the best approach is, but that's kind of the stance that we've taken in collaboration with our GYN team.
Yeah, we require, I guess, parental consent, but we also require patient assent. So, I guess that for us would exclude all mentally disabled patients because they can't give assent. But because, you know, if they're not 18, the patients can't consent, but we do require them to agree to the exam.
One thing I think is super interesting to think about with these exams is in many of these patients, they would be considered emancipated minors by like legal definition. So if they're doing something for family planning purposes, which is totally a legal definition, not a medical definition, you actually don't need consent from the parent to, first of all, let me back up. This is state dependent. And different states have different requirements for what is needed. But I always have to remind my techs, in some situations, you cannot talk to the patient's parents without her consent. For family planning purposes is one of them. So if somebody is pregnant, you are not allowed to talk about that in front of their parent unless they give us consent for you to do that. So it's just really fascinating with a lot of different things to think about. We kind of have similar guidelines as Leanne. 13 is our age cutoff. You know, they have to be at least 13 or older to be doing these. And then we also run into the same issue with patients who can't grasp, they can't understand what we're going to be doing just due to, you know, mental capacity issues. I find those very challenging because sometimes those patients would definitely benefit from a transvaginal ultrasound. You know, sometimes those patients are larger, and so the transabdominal imaging quality is a little bit worse. And sometimes I think we would be able to problem solve and not have those patients go on to MRI, which often need at least a little bit of sedation, depending on the patient. So I also don't know exactly the right answer. I think teamwork, collaborative discussion is probably best.
Yes, totally agree. The other kind of question I had for discussion was, if a patient comes in, female adolescent with right lower quadrant pain, do you allow them to do appendix and pelvis exams separately? I know in my fellowship, we always did those two exams together. So if they were, you know, came in with right lower quadrant pain, adolescent female, we did not let them do just an appendix by itself or a pelvis by itself. Do you guys have a similar approach, or how do you guys handle that?
I guess we have a combo here at CHLA, but we had it separated, at least at Texas Children's before I left. So I guess it can go both ways. But for us, the appendix and pelvis combo is actually driven more so from the ER and our clinicians than us implementing it. Like as in radiology saying you need to order both.
Yeah, same. I mean, every ultrasound has to be ordered separately. You know, I think probably in their order set from the emergency department, they can just click one, you know, right lower quadrant pain female, and it, you know, it orders the right lower quadrant ultrasound and the pelvis ultrasound, but they can order one or the other.
And then as far as the full bladder, I know you'd mentioned, Leanne, you know, it's definitely ideal for a patient to have a full bladder. There was this paper I found interesting that was published a couple years ago in Pediatric Radiology I think it's kind of a similar concept to appendix exams. If you have a non-visualized appendix, it's probably negative, because if you have, you know, that enlarged appendix and it's inflamed, you're pretty likely to see it. I think it's a similar concept with non-visualization of the ovaries. You know, if you have an enlarged ovary, you're probably going to see it, even if you don't have a full bladder. So, you know, for most of our exams, we still do have a full bladder, but, you know, the main thing we've run into is we have one site where we have sonographers that are on call in the middle of the night that they have to come in from home to scan these exams, and they'll get there at 2 in the morning, and the patient's, you know, says they're full, but they're not really full. And then they have to, you know, sit there theoretically for an hour or two, however long, to wait for those patients to fill. So in that instance, I have told the sonographers, you know, do your best to try to time your arrival with when the patient's full. But if they're not full, then just go ahead and scan them. I don't want you to sit there for 2 hours waiting in the middle of the night. Have you guys taken a similar approach or run into that issue, or how have you kind of approached that?
We leave it up to the discretion of the sonographer a lot, like what they feel like they can see and can't see. We're super lucky that at all of the sites we do ultrasound, we have techs in house, so they can send the patient back up to fill a little bit more. You know, I give my sonographers a lot of discretion. One thing that's kind of interesting that's come from this is our ED, in collaboration with us, has created some clinical effectiveness guidelines that from triage, when a patient presents with a female with right lower abdominal quadrant pain presents, they automatically start filling the urinary bladder from triage before a physician has even seen the patient, which is kind of, I think it's, my ED colleagues are under a tremendous stress to increase throughput. So I think from that standpoint, it's good. We run into issues when we scan the patient before an emergency doctor or advanced practitioner has even seen the patient. I don't know how you guys deal with that.
I feel like, oh, go ahead, Leanne.
I was just going to say, we're actually in the process of, we have a little bit of an interesting situation in that our ERs at our 2 different hospitals have 2 different physician groups. One is a private practice group and one is an academic-based emergency physician group. And as one might expect, we have about 6 times the number of ultrasounds from the private practice site. So we're actually, we are specifically looking at right lower quadrant ultrasound, not pelvic, but we have noticed that most of our ultrasounds come before a physician has seen the patient, lab work has been ordered. So, you know, no exam, no labs, like, do they have appendicitis? Well, you know, if we can't find the appendix, like, what does that even mean? So, you know, it probably wouldn't make much difference at one of our sites if they started filling the bladder and ordered the ultrasound from triage. That's not what happens. They're ordered by physicians, but you know, the physician sees the chart and says right lower quadrant pain, send them to ultrasound, and they don't even see them. So triage versus a physician reading the chart probably doesn't make much difference.
All right. And then the kind of next steps in our pathway. So this is kind of our practical approach to a lot of the things that Leanne discusses, you know, as far as how to actually think about torsion. And like you mentioned, Leanne, I think totally agree. This is really a kind of a team approach is really best for this. I think that it's really challenging when we're kind of isolated in radiology to interpret these exams. So we've kind of tried to incorporate a lot of what you said into this clinical pathway. So when we interpret these exams, so we have 4 different template categories that we can put these into. And so I've kind of listed them down here. So we mainly depend on the volume and the ratio to put them into one of these 4 categories. So you'll notice that the middle one, so if we call it either low probability or high probability, so that's volumes of 20 to 100 or greater than 100, and then with those ratios, you'll see that both of those actually get shunted to this next box here, which is basically they try to treat either the pain or the vomiting. If either of those resolve, then they can discharge the patient. If they persist over that period of time, then they are supposed to consult GYN. So I'll show you a couple of cases as to where I think this really has a lot of value. But that's kind of how we've approached this. We've had some real logistical challenges with a couple of the things you mentioned. Number one, with that calculating that score, for us to know whether the patient has vomiting or not, I think that's a challenge just for us to get that clinical information. And then same thing with the premenarchal versus postmenarchal. That's really, I think, a challenge for us to categorize those as far as our report goes. So at least as far as how we report these, we haven't incorporated those 2 pieces of information into our actual reports, but we have tried to incorporate it into this pathway. So that's kind of our approach to how we kind of dictate these exams, trying to incorporate some of those scoring systems and other things that you had mentioned. I also noticed on one of your slides that you have something similar to what we do. So we have this built into our machine where the ovarian ratio is automatically calculated for us. And there's a spot in our template where that number automatically gets populated over. We also calculate this uterine to ovarian ratio. One of our GYN providers has done some research in this area that the idea is that when girls hit puberty, the ovaries enlarge quicker than the uterus does. So they theoretically have, more empty space in their pelvis, with a small kind of premenarchal size uterus, and the ovaries get larger. So there's, theoretically more space for that twist to occur. We are not using that in clinical practice, but that's why this number is also kind of calculated on there. The next thing I wanted to discuss, there's this paper that was published about, I know we've talked about MFI or microvascular imaging in some of our prior sessions that we've had. This paper kind of suggests that it's might be helpful for looking at the ovaries. I have asked the techs to start at least trying this. We haven't really started using it in practice. I don't think there's been a case where I've changed what I've said based on the MFI images. I'm curious if you guys have started using this for ovaries, or kind of what your experience is with it so far.
I'm definitely trying to use MFI in microvascular imaging more often in all body parts. So I guess more to learn about that. But like you said, vascularity or blood flow can be tricky with these ovaries. So I'm not too sure if I feel like the ovaries tors, if putting on, kind of microvascular imaging and there is blood flow, like what would that mean? But I guess if you're thinking, oh, maybe there's an absent flow, and then you put this on and there's no flow, and you feel like it's not technique related, like the patient's not too obese, or you're getting like decent signal, then maybe that can further help. But then if in a normal size ovary, like, would you, lean towards torsion or not? So I feel like it's so far a little tricky.
Also, I feel like motion impacts our these MVI techniques maybe a little bit more. I still like our techs can use it in addition to both color and power Doppler, but we have not yet replaced any of the other Doppler techniques with any sort of MVI or SMI or B-flow, whatever it is on your machine. At least not yet. I still like the grayscale appearance more than anything still.
Yeah, I agree. All right, now it's just to run through some cases just for kind of, practical approach to how do we think about some of these. So this was actually what triggered our whole kind of thought process and creation of that pathway that I showed you, and kind of rethinking how we think about these. So this was, a pretty normal looking ovary. We can see, some questionable arterial waveforms here. The volume was, still on the lower side, but the ratio was kind of around 5. This patient actually ended up getting taken to the OR on the basis of clinical symptoms, and this ovary ended up being torsed. So I think this really just highlights how challenging of a diagnosis this is from the radiology perspective. I think that, Leanne, the ACOG guidelines that you showed, one of the other things they mentioned, I believe, is that a negative laparoscopy rate of up to 50% is acceptable in these cases of torsion. So I think that it depends on, provider to provider, but I think they really can have a pretty low threshold to take these patients to the OR. But like I said, I think that just highlights how challenging this can be from an imaging perspective. I don't think anybody would ever call this torsed, and it ended up being torsed. By our pathway that I showed you based on the ratio, this would be put into that low probability category and hopefully, get shunted towards, clinical observation and assessment of pain and vomiting. And, this patient did end up going to the OR, as I mentioned, but again, just a really challenging imaging diagnosis.
Hey, Jeff,
Sorry, go ahead.
Before I forget, it used to be, and I really should look, like, I'm sure it's been updated. It used to be one of the ACR, like accreditation, like checklists for pelvic ultrasounds to know the LMP of a patient. So like one suggestion that might be helpful is have your tech start putting that on the face sheet for all of these kids, and that might help you with that scoring thing. So I should have mentioned that a couple of slides ago, but
yeah, that's what we do.
Great idea.
We have our techs ask the LMP and they put it on the face sheet of the ultrasound. And if, the patient's on depot or hasn't started yet or something, they'll put that on the face sheet as well. So I would be curious with this case, you say this is an adolescent, but that's a pretty broad age range. Had this patient started her period yet?
I don't recall. This would be interesting. Like you mentioned, the premenarchal ones, the volume ratio or the volumes are, the criteria much stricter. I'd have to look at that, but that's definitely a good point. And
yeah, because one of the things that, we found in the study we did in Cincinnati a long time ago was that in menarchal patients, if it was smaller than 20 milliliters, it was not torsed. There were 0 patients that had an ovary smaller than 20,
right,
started their period that had torsion. So I would be curious to know what this patient's menarchal status was.
right. Yeah, I'll definitely have to look back at that. Yeah, and I think that's definitely a great idea about the LMP. I have noticed our techs, I feel like, do that more frequently on outpatients, when they're wanting to measure the endometrial stripe for abnormal bleeding or something like that. I feel like we do it more commonly on outpatients, but that's definitely a good idea to do it more frequently on all these patients.
Yeah, because aside from the LMP, I mean, as the technologist is scanning, maybe, in the front portion of it, and they can just type in like vomiting or pain X days.
Right.
Because we usually give like that minor history. And then also about this case, like I feel like the right ovary is more midline, because on your midline clip, you can see a lot more of the uterus.
Right.
Maybe that's another sign that
Yeah.
it could be torsion.
Yeah, definitely a good observation. All right, so next case, so this is kind of the other end of the spectrum. So I think this is one of my pet peeves. This is like my equivalent to Judy's hemangiomas is they always put comment on blood flow to ovaries, which we all know is not a good indicator. But this was just a very large, simple appearing cyst. Like some of those cases that Leanne showed, we can see, there's little dots of flow along the periphery where that ovarian parenchyma is. We can see there is a waveform here. So this was a patient that this did end up being a torsion. So again, just highlighting that, you have this big simple cyst, the volumes and the ratios are definitely in that range where we would be concerned about this. So this is, again, just can't rely on flow to exclude the diagnosis of torsion. This is just a similar companion case. So this ended up being a torsed dermoid. So you can see we labeled a couple different cysts here. So a smaller one here, some ovarian tissue, and then this larger cyst with kind of this mural nodule along the side of it. So again, we can see that it looks like there is some flow with waveforms obtained from that, a little bit of ovarian tissue. But again, this ended up being a torsed dermoid, as I mentioned. The next thing I kind of wanted to discuss, so this was a patient came in with right lower quadrant pain, had this CT, had this big, nasty looking ovary. So this is ended up being a torsed ovary. It was, completely necrotic. They ended up just taking the whole thing out. I'm kind of curious how you guys approach that when you have a CT as the first imaging modality. In a case like this, do you feel like ultrasound adds anything? And then kind of vice versa, sometimes we get those cases like I showed you where they, ask us to comment on blood flow to the ovaries. We actually had one just yesterday where they had a small hemorrhagic cyst that was seen on an MRI done for a different reason, and they subsequently ordered an ultrasound to just get to specifically look for torsion. So I'm kind of curious what you guys' approach to is when you have a different modality other than ultrasound. Do you think that ultrasound adds anything to a CT or an MRI if you have those already?
I think there's this sort of mantra in the radiology lore that, like, if it's female pelvis, you go to ultrasound. And I honestly think we probably don't need to get a subsequent ultrasound as much following, especially when the preceding study was an MRI. I feel like usually MRI tells us more information than the ultrasound, and oftentimes, honestly, so does CT. Now, if I think it's like, maybe this is like jumping topics a little bit, but if I'm going to recommend that a cyst or, some sort of funky lesion goes away, then I'll be like, well, in 6 weeks, then get the ultrasound in 6 weeks for the follow-up. But in the immediate setting, I don't really feel like it adds very much. I feel like if the patient has pain, there is a known lesion, or it's torsion, like, it's not going to add value to the care of that patient most of the time.
Yeah, I totally agree. I think the ones I struggle with the most are when we have a CT and the ovaries look completely small and normal, and they want to get a subsequent ultrasound to exclude torsion. I really feel like there's no indication. So I'm glad it sounds like you agree with that.
Sounds like a good study for you to do, Jeffrey.
Yeah,
I'll send you all my cases.
Yeah, it'd be interesting to see like how accurate our volume calculations are on CT compared to ultrasound, just to see if we can use some of those similar scoring systems, and reliably, like you mentioned, if you have a small ratio, small volume, can you reliably exclude torsion on a CT? So next case, this was just to kind of show the other end of the spectrum as far as these kind of in utero torsion. So this was the prenatal ultrasound. So I had this cystic lesion down in the pelvis. There's a pretty wide differential for what this could be. Lymphatic malformation, duplication cyst. This could be ovarian cyst. So we do ultrasound after they are born just to see what's going on. So this patient ended up having this big hemorrhagic cyst within the ovary. Subsequently, was imaged another month later and had involuted a little bit. So this ended up being a torsed kind of in utero. So I think that just kind of showcases the other end of the spectrum as far as, not all of these are just typical adolescent torsions. You can also have these kind of prenatal torsions as well. And then just kind of a nice companion to that. So this was a patient we just recently had. So this was an infant that came in with concern for NAT. So had a abdominal CT done. So had these kind of two hypoechoic looking things here. So initially, given the history, I think there was some bias. And initially we thought these were potentially these hematomas. So that was what they were kind of initially called. But subsequently had a ultrasound just to get a better look at those. So this is, very typical morphology for these. They ended up just being ovaries. So I think that just kind of nicely shows that these female infants can have that, maternal estrogen hyperstimulation. They can have all these big follicles, and their ovaries can be quite large. So just to kind of keep that in mind when you're looking at these younger patients, that they can definitely have very kind of enlarged ovaries. All right, so kind of now moving away from torsion, just to talk about some other female pelvis. So this is a case of a contrast ultrasound that I thought was really cool. Just wanted to share with you guys. So this was a patient that came in with congenital adrenal hyperplasia. They had really had quite a bit of difficulty in defining this patient's anatomy. So they thought that there was a single perineal orifice, and they had done a cystoscopy, and they really couldn't identify where the vagina was. They had this MRI where you could see the bladder. You can see this kind of fluid-filled structure, which was felt to represent, fluid in the vagina. But they really, on this MRI, it's really difficult to see any connection there. And then, as I said, at cystoscopy, they could not see any connection there either. So we did this contrast ultrasound just to hopefully better see that. If you kind of focus right in this area right here, you can see very nicely, I think you can see the swirling of contrast. So behind here, so this is all contrast that's kind of flowing into the vagina. This is the bladder here. So I thought this was really a nice case. I think this really added a lot of value beyond any other imaging modality that we could really offer. I think we could have potentially seen this on fluoroscopy. This patient had a BCUG a long time ago before they were really aware of what this patient's anatomy was. So I don't think they looked quite as closely as we could have, but we did not identify it on that BCUG. But I think this exam really just nicely showcased that. So this main thing we were trying to define was where the confluence of the vagina is. So you can either have a low confluence or a high confluence, and that really just changes their surgical management. So this definitely ended up being on the higher side. So again, just really kind of a nice example of how nicely that contrast ultrasound showed that. And then another contrast ultrasound. So this was an older patient. So this patient had a history of a distal vaginal agenesis and then had a colonic vaginoplasty, and then came in much later in life. Now it's kind of recurrent pain and bleeding. So similarly, they had an MRI done first. So they had a tampon placed into the kind of neovagina just to kind of help define the anatomy a little bit better. I think you can see this maybe little thin band of tissue right here, but it's really, I think, quite difficult to define their anatomy. So we went to contrast ultrasound. So this is, I'll play through this little cine clip here, but so this component, this is the colonic vaginoplasty. This part back here is the native vagina, and then this is all contrast that's within the endometrial cavity. And then this right here, I think, is where the anastomosis is. But as I play through here, you can see that thick kind of band of tissue going across there. So I think this just really nicely, again, showcases there's, pretty high-grade stenosis at that anastomotic site. But again, I think that contrast ultrasound, I think, really can add a lot of value in these otherwise confusing kind of female pelvis cases. Have you guys had similar experiences? Are you guys using contrast ultrasound for this? Similar indications, or what's your experience been with these so far?
Not a ton, just a few cases. I know Harriet has done several, the anorectal malformation patients preoperative planning. So some places do it. Those are
We
beautiful.
are doing it for like newborn anorectal malformations, but we haven't been doing it for cases like this. I think either they get an IR study or just a Flora VCG.
Yeah. I think it definitely dependent on your kind of local referring clinics. So, we have a very large anorectal malformation population here. We haven't quite started using it for that, just because I think they're so familiar with fluoroscopy. I think it's definitely an avenue we could explore further. It's definitely an interesting concept, and I think, like I said, and I've seen some of those cases from Boston with the the high pressure colostograms that we do in fluoro. With ultrasound, you don't even have to use the high pressure component just because you can see those little trickle of bubbles through. So maybe it's a little bit safer, but definitely interesting to think about. So next case, so this is a patient, adolescent that came in with a history of chronic kidney disease. So they were doing a renal ultrasound and just happened to see this thing when they were looking at the bladder, this big vascular mass within the uterus. So this patient also had a kind of complicated history that she had a cochlear implant, so it was not a great candidate to have an MRI done. So I just wanted to kind of show you guys this, that we're starting to do more 3D ultrasound, just to kind of see what we can do with it transabdominally. I know it's really well established in the adult population for more transvaginal ultrasound looking at 3D, but we've started trying to do it with transabdominal ultrasound, and I think we've had some pretty good results so far. So this is showing you what we could see on 2D imaging. So we can see this mass, we can see this is the IUD in here. Kind of can see this septation potentially in here, but I think it's really difficult to define what her anatomy really is. So when we went to do 3D, so again, you can see this mass right here. You can see that the IUD, you can see part of it is in this other component of the endometrial cavity. So it looked like there was some kind of Mullerian anomaly. So it looked like there was this kind of septation in here. So because of all this, and she had a lot going on, they ended up deciding to pursue an MRI. So it's quite an ordeal. So they have her particular cochlear implant. They had a MRI compatibility kit that they could apply that she could receive an MRI. But it's really quite painful just because of the way they have to position them within the magnet. Where the cochlear implant is was the site of the greatest magnetic pole. So it's really quite painful for her. And I would argue it really didn't add all that much information. I think this image we have on this MRI here is basically the same image we already had from our 3D ultrasound. So this patient is still being worked up. So she's scheduled to go to the OR and get a better look at this in a little while. But that's just kind of highlighting our use of 3D. We don't actually have a dedicated 3D probe. This is just done just manually with our standard probes. At least with our software, it's built into all of our machines that any probe you can do a 3D acquisition. It's definitely a skill component to it. They have to do the acquisition smoothly, and they have to do the 3D reconstructions on the machine. So they don't always turn out all that well, but you know, it's better than nothing in a lot of cases. So we've started trying to do this more. I'm curious if you guys have any experience with doing this, or if you guys have any thoughts on this.
I have not done it with just a normal probe. So that's really interesting to know that you can, and I'll probably have to look into if our software allows for it. But I feel like even with the 3D probe that we did have for mainly for OB, like you would still have to do a lot of the manipulation either on the scanner or, you know, in a separate like software, which I forgot, maybe AS or something like that. So like a different software too. So I guess it's nice to be able to have that option. But I don't know if you can get away from all that manual stuff.
Yeah, at least the way our system is set up is the 3D probes have a little motor built into them, and you just hold the probe still, and then it does the sweep for you. So our probes have the capacity to, you have to manually sweep it yourself rather than having that automatically done for you. The 3D probe goes at the exact right speed you're supposed to go, and it does it more smoothly, I think, than doing it manually does. So I think we would probably get better quality images if we had a dedicated 3D probe, but we're kind of trying to do proof of concept just to show that it works before we can convince our department to buy it for us. But I think it's at least been interesting to see what we've acquired with it so far. I have a couple other cases just to kind of, again, show you similar. So this was a patient that came in with abdominal pain and menorrhagia. So in our 2D, we can see this kind of septation at the level of the cervix, and then higher up, you can kind of see there's, maybe 2 separate endometrial cavities, but, really quite limited on the 2D acquisition. But with this really nice 3D, you can really see that septation extending down the length of the uterus. So this was a abdominal pelvis MRI that was done for a separate indication. So this image quality is not quite as good as our dedicated pelvic protocol that we do for these. But again, I think, I'm not sure that MRI adds a whole lot of additional information beyond what we already got from our ultrasound. And then just also showing you can do this for IUDs, similar to what you can do with transvaginal exams in the adult population. So this is just showing this, you can see the T's bar of the IUD. Looks like it's appropriately positioned at the fundus in this case. This was one that was malpositioned. So we can see the fundus up here, and then the IUD is kind of low lying and kind of tilted a little bit. So again, it's not the prettiest images, but I think it definitely adds a little bit to kind of our standard 2D images that we can get in these patients. All right, next case, this is a patient that came in with left lower quadrant pain. I'll play through this little cine clip here for you. So this is the volume is right a little bit above 10. You can just see numerous follicles kind of all throughout this. I'm kind of just curious how you guys approach this concept of, PCOS or PCOM in our adolescent population. At least at Children's, this is the kind of guidelines that our groups use. This guideline says that you should not use it for the first 8 years after menarche, just because there's a very high incidence of this polycystic ovarian morphology. So it's not true PCOS, it's just the morphology looks similar. So this is kind of what they've asked us to say, just to kind of describe it and say that it can be normally found in adolescents. There's still some patients in that group that do have PCOS, but they just feel that the imaging is not a contributory component of that. Have you guys had any similar conversation there? Do you guys have any thoughts on how your group approaches this?
Similar. I think the clinical setting is super important in this population, especially. What's interesting in the adults, I think all of the things are based on transvaginal ultrasound imaging also. So, clearly we need to better define in the pediatric population, or potentially consider adopting some of the adult criteria into our imaging. But I still think this is another one of those collaborative approach diagnoses. It's important to report it, but not say compatible with, this is definitely PCOS,
All right, and then I believe this is my last case. So this is a patient. This was just a totally incidental ovarian cyst. So you can see I have the measurements on here. So this is up to about 6.2 centimeters. So overall simple in appearance. I think there's probably a little bit of kind of just compressed ovarian tissue along the side of it. So I wanted to just bring this up to kind of talk about a little bit about how you manage these cysts. This is the kind of SRU consensus guidelines for adults. Do you guys follow these for kind of pediatric adolescent patients, or what's your general approach to recommendations for following up incidental ovarian cysts?
The problem with these SRU guidelines is that they exclude patients under 18. But even in that light, cystic ovarian neoplasms are, well, the type of neoplasms that occur in adults that, that they're typically looking to see if these turn into are less common in the pediatric patient population. So I sort of personally a little bit incorporate them. I would love a society and some consensus of experts to come together with maybe a little bit of data to study it and then create guidelines for us. Because I do think we probably follow these simple cysts a little bit too closely.
And then similarly, like for like a hemorrhagic cyst, like you had mentioned previously, do you kind of have a size cutoff where you just let it go versus when you would recommend that 6 to 8 week follow-up, or what's your kind of approach to more the hemorrhagic cyst type situations?
Size. I extrapolate from the adult population, even though pediatric patients are excluded. But it also depends kind of like what it looks like. If the patient has pain, I feel like typically they end up going on for concern for superimposed torsion anyway.
Right. Yeah. Overall, I totally agree. I think it'd be nice to have, something more pediatric specific, because, it's definitely not uncommon that we'll see these things. And I personally struggle with, knowing exactly what to do with them. So I think it's definitely something would be nice to have.
Yeah, I think we always forget about how expensive pelvic ultrasounds can be.
Right.
It's no radiation, but we forget about it obviously it depends where you are, but they're not cheap studies. So.
Right. Yeah. And I know that was one of the interesting things that that one scoring scale that since Leanne had shown from Cincinnati, they actually have a specific paragraph in that paper that says we should consider not even doing Doppler, and even if there's concern for torsion, that the Doppler charge is really quite expensive.
I completely agree. It's like it doubles the price at most sites.
Right.
Yeah.
So.